So good morning, everybody. We will miss today the sun and the sea, because of, but what to do? So this is the title of my talk, The Impact of MDR Pathogens in the ICU. My disclosure, of course, and the outline of my talk. I will divide it in three parts. The first one will be devoted to the prevalence of MDR pathogens in the ICU. The second part to the attributable morbidity, mortality, and cost. And we will review together the methodological difficulties for exactly calculate those attributable morbidity, mortality, and cost. And finally, we will review some data showing how much the increase in antibiotic resistance could compromise our ability to treat those infections. So as you know, we are now facing a lot of infection in the ICU caused by MDR pathogens. And I will take only one example, but this is really a worldwide issue, of course. As you can see on the slide, most countries in the world are now facing very bad bugs, gram-negative bacilli, resistant producing Carbapenem-R, and therefore resistant to the last resort beta-lactam we have. And as you know, this is really a very problematic issue. And very importantly, things are really very concerning. This is the data we got in Europe. As you can see, from 2008 to 2013, really the dominoes are really falling, as you can see. And now most European countries are really in a bad shape regarding those infections, very difficult to treat. This is exactly the same in all other countries in the world, in the US, Latin America, or Asia, as you know. And things are now very complicated because now it's possible to isolate some Carbapenem-R producing gram-negative bacilli, but very importantly, the gene coding for the resistance to carbapenem is now on a plasmid, the MCR1 plasmid. And this is really a catastrophe, as you know, because based on that, the resistance to carbapenem could go from one bug to another very easily. And therefore, there is a real threat for outbreaks in the ICU based on that. And as you know, those bugs are now not only resistant to carbapenem, but also to colistin, the MCR1 gene code for colistin resistance. And as shown on the slide, treatment of those infections is really very difficult. We have only maybe one drug, in some cases, still efficient for treating those infections. So this is really a catastrophe. Of course, the situation is not exactly the same in all countries. And the MDR, XDR pathogens we are facing are not exactly the same in European American countries or maybe in China or other Asian countries. This is one study comparing the microbiological data collected in Asia and in Europe and in the US. As you can see, Acinetobacter baumannii is really one of the major bugs in Asia. It's a little bit less in Europe, even in some countries we can observe very bad outbreaks, of course. So this is, there are some differences, but this is really a worldwide issue, as I said before. The only good news, but this is the only one, is Staphylococcus aureus resistant to methicillin. In every country, probably now, the prevalence of the infection caused by those MRSA isolates is decreasing. And this is a good news, of course, even if in many countries the proportion of Staphylococcus aureus resistant to methicillin is still roughly around 15–20%. So, okay, things are improving regarding that pathogen, but still we need to consider MRSA when we are selecting the initial antimicrobial treatment, of course. Anyway, as you know, and this is really the major factor driving the emergence of MDR pathogen in the ICU. This is the overuse of antibiotics. As you know, we have a lot of data, a very strong data, showing the relationship between the total amount of antibiotics we are using in one country, one hospital, one ICU, and the proportion of strains resistant to that particular antibiotic. This is one example in the US, showing clearly the relationship between the total amount of fluoroquinolone, for example, used in that country, and the prevalence of strain resistant to fluoroquinolone. There is a direct relationship between the two, as you can see. Of course, antibiotics do not really create the resistance to antibiotics. It's possible in some cases, but the most important factor is the selection pressure caused by the use of antibiotics at the level of the site of infection and also at the level of the digestive microbiota, for example. And as you know, this is a major factor related to the prevalence of MDR pathogens, particularly in the ICU. We need to remember that most antimicrobial agents we are using for killing microorganisms were in fact invented by the microorganisms themselves to defend their territory. The best example, but this is only one example, is penicillin, as you know, as shown on the slide. But remember, all antibiotics we are using were in fact first invented by the microorganisms themselves. This is a very important thing to know. And we have now very good data showing that many years before human beings having reinvented antibiotics, that it's now possible, you know, to dig very deeply in the permafrost, for example, collecting the microorganisms present 30,000 years before now, and therefore before any invention by the human beings of any antibiotics. In those bugs, it's possible to find the element responsible for resistance to antibiotic, exactly the same structure that, for example, for vancomycin resistance, exactly the same element in those very old bugs and the bugs now we are facing. So clearly showing that antibiotics were invented by the bugs themselves to be protected against the antibiotics they are using for defending their territories. What is the attributable morbidity, attributable mortality and cost of those infections? We have a lot of data, once again, showing that the mortality in infection caused by MDR pathogens is increased compared to infection caused by more susceptible pathogens. This is one example, but we have many studies showing that. For example, in ESBL versus non-ESBL gram-negative bacilli, there are clearly an attributable mortality as shown on the slide. The relative risk as shown in that meta-analysis is roughly 2.0, as you can see. But remember, there are a lot of methodological difficulties for calculating very precisely this attributable mortality. There are some confounders, of course, age, sex, comorbidities, the source of the bloodstream infection, for example, immunosuppression, of course, community versus hospital-acquired infection. Because as you know, those factors are driving the severity of the disease at admission into the ICU. And of course, the disease severity is directly related to the risk of developing a nosocomial infection and also directly to the mortality as shown on the slide. But there are also some intermediate factors. For example, the sepsis severity. Of course, the sepsis severity, source control or absence of source control, the adequacy of antimicrobial therapy are also factors driving the mortality observed. So to calculate the attributable mortality, you need to take into account those confounders and also those intermediates. And this is very difficult because this is, of course, based on observational data. It's not possible to randomize patients to infection caused by MDR pathogen or infection caused by a susceptible pathogen. So a lot of methodological difficulties regarding the way for calculating this attributable mortality. And this was nicely demonstrated, for example, in that paper from Rothier, published in the Journal of Antimicrobial Chemotherapy 5 years ago. Of course, pulling all the data we have based on those observational studies, it was possible using multivariate analysis to calculate the attributable mortality. As you can see, roughly 1.5 in that case. But if you take into account the confounders a little bit better, and more importantly, if you take into account the intermediate factors, the severity of the sepsis, the fact that the source of infection was controlled or not, and very importantly, the adequacy of the initial therapy, you will find a more benign attributable mortality, going from 1.5 to only 1.3, for example. So this is one of the difficulties. But clearly, of course, there is a price to pay in terms of mortality and morbidity due to the resistance to antibiotics. But also, for the bugs, there is some fitness cost, making difficult for the bug to be very virulent in case of infection. Of course, not only there are some attributable mortality and morbidities, but also the cost of those infection is very important. As shown on the slide, in that meta-analysis and systematic review published a couple of years ago, it was very easily calculated that, for example, for carbapenem-resistant non-fermenters, Pseudomonas aeruginosa mostly, the attributable mean hospital charges were between $60,000 US and $85,000. So a lot of money, of course. Exactly the same for ESBL producing gram-negative bacilli, a little bit lower, of course, and for MRSA. So, as I said before, MDR pathogens heavily compromise our ability to correctly select the initial antimicrobial therapy and oblige us to use more and more broad-spectrum antibiotics in a very vicious circle, of course. And this is really concerning. As you know, and as I said yesterday, we have a lot of data showing that the initial therapy is really a key issue. If we are not able to select initially the most appropriate, adequate therapy, we will get a very high impact on the mortality caused by the bug and the infection. This was clearly shown, for example, in that study. Why? Because, of course, in that case, when the infection is caused by a very difficult-to-treat pathogens, it's more difficult to select the initial antimicrobial therapy. As shown on the slide, the 5 more important players in that issue are Pseudomonas aeruginosa, Acinetobacter baumannii, MRSA, still an issue, and ESBL producing gram-negative bacilli, including Carbapenem-S producing strains. Based on that, we are obliged to use a very broad-spectrum regimen initially in order to cover all the possibilities, particularly when the infection is severe, for example, in septic shock, of course. In that case, it's not possible to use initially a very narrow spectrum regimen, of course. You need to cover all the possibilities. But, of course, in many cases, the infection will not be caused by a XDR pathogen. And this is why it's so important to be able to identify the pathogens responsible for the infection in order to be able to de-escalate on day 2 or day 3 once you get the results from the lab. This is really a very important take-home message, of course. Remember, bombing ICU patients with antibiotics can be detrimental, really. Drives the emergence of MDR pathogen, the vicious circle, as I said before. It can render difficult or impossible the identification of the microorganisms responsible for the infection, leading to suboptimal therapy. It can also mask the true diagnosis or delay the control of the infection source, as shown by Jan yesterday. In many patients in the ICU, source control is a key issue for decreasing the morbidity and mortality associated with infection. And we have a lot of data showing that. This is one of those studies showing that the major risk factor for an infection caused by a carbapenem non-susceptible E. coli bloodstream infection, for example, is the previous use of carbapenem in the ICU. As I said, targeting MDR pathogens may lead to suboptimal therapy sometimes. The best example is MRSA infection. As you know, in that case, when the infection is caused by an MRSA isolate, you need to use vancomycin most of the time, or linezolid. This is the two most used antibiotics. But be careful, because if the infection is caused by a susceptible strain, and methicillin susceptible Staphylococcus aureus, in that case, using vancomycin or linezolid, even linezolid, is not the optimal therapy. And this is very important because, of course, you need to take into account the possibility of MRSA, but you need also to cover correctly MSSA. This is very important, and we have very good data showing that using vancomycin for treating MSSA is a mistake with a much higher morbidity and mortality. This is one of those papers clearly documenting that. Finally, the emergence of antibiotic resistance, including XDR pathogens, further complicates infection control policies in the ICU, requiring very strict and very expensive measures. This is the data we collected in Parisian hospital last year regarding the detection of a few cases of patients colonized or infected by carbapenem-resistant strains. Only a few cases, because for the moment we are pretty lucky. The prevalence of those infections is very low, caused most of the time by patients admitted from a broad hospital. As you can see, the costs associated with those bugs were pretty high, particularly in case of a small outbreak. When a secondary case was observed because of a breach in the infection control measures, in that case, the cost was roughly 50,000 euros. Of course, if only one case was detected, the cost is much lower, of course. This is why it's so important to be to have the possibility to detect immediately patients colonized by those bugs in order to be sure to avoid secondary cases. So in summary, we are now on the very edge of the abyss. So the situation is really alarming. And we have only a few solutions to that, only two, in fact. First, improve antibiotic stewardship, particularly in the ICU, and also being able to reinforce infection control measures. Easy to put on a slide, but in the real world, at the bedside, it's much more difficult, of course. Thank you so much for your attention.